Hello, my name is Dr. Alex Herrera. I'm a professor in the Department of Hematology and Hematopoietic Cell Transplantation at the City of Hope in the Los Angeles area. I'm the chief of our division of lymphoma and one of the medical directors of our clinical trials office. Welcome to this program entitled Key Lymphoma Abstracts from the American Society of Hematology Annual Meeting 2024. I'm pleased to be joined today by Dr. Matthew Lunning. He's going to be joining us in a little while, hopefully. He's an associate professor in the Division of Hematology and Oncology and the medical director of the Gene and Cellular Therapy Program at the University of Nebraska Medical Center in Omaha, Nebraska. And we'll welcome him when he's able to join. So today we'll be discussing some of the news in lymphoma out of ASH 2024. We'll focus on just a few presentations in follicular lymphoma, diffuse large B-cell lymphoma, and classic Hodgkin lymphoma. So we will start off with follicular lymphoma. The first abstract that we're going to discuss focuses on loncastuximab tesirine with rituximab. And in this abstract entitled Lonca with rituximab induces robust and durable complete metabolic responses in high-risk relapse refractory follicular lymphoma. So this was a phase 2 study presented by Dr. Juan Alderuccio from University of Miami. Patients received loncastuximab and rituximab for 4 cycles as part of the induction therapy. The lonca was for 4 cycles, the rituximab was for the first 3. For the first 2. Patients then had a PET scan after those initial 4 cycles. If they were in a response, they would continue to receive lonca-R as a kind of initial maintenance. And if they got into a complete response at that point, they would just continue rituximab for continued maintenance. If they were in ongoing partial response, they would continue to receive lonca-R. If they progressed at any point, they were off treatment. Patients with relapsed refractory follicular lymphoma with at least 1 line of prior therapy were included, and the primary endpoint was response. The study enrolled 39 patients. It was pretty even of a split between refractory and relapsed patients. The median prior lines of therapy was 1, although there were just under a third of patients who had received at least 3 lines of prior therapy. Most of the patients enrolled had received prior R-CHOP, some had received bendamustine, and others received kind of a smattering of other regimens. Therapy with lonca-R was relatively kind of well tolerated. The toxicities observed were those that we expect and have come to know with loncastuximab and ADCs that have a PBD dimer. There were cytopenias. There were some liver function test abnormalities. Hyperglycemia was observed, and there were these rashes that we observed that are photosensitive. The response rate at week 12 was 97%. The complete response rate at week 12 after the lonca-R induction was 67%. And the overall best response rate was 97%, and the overall best complete response rate was 77%. And so in terms of the durability of these responses, the 6-month PFS was 95%, and the 12-month PFS was 95% to lonca-R, and the overall survival at 12 months was 94%. So, just in terms of the key takeaways from this abstract, limited duration lonca-R delivered a significant complete response rate in second-line later follicular lymphoma in patients with a high tumor burden. There were patients who had progression of disease within 24 months on the study. The study did meet its primary endpoint with a complete response rate greater than 50%. The durability of the complete responses appeared excellent. There was a 12-month progression-free survival of 95%. And the safety profile of loncastuximab with rituximab in follicular lymphoma was consistent with the prior studies that we've seen in B-cell lymphoma with no new safety signals observed. We'll move on to the next abstract. This was an exciting late-breaking abstract in patients with relapsed refractory follicular lymphoma it was a randomized phase 3 study, the INMIND study, evaluating tafasitamab plus lenalidomide and rituximab compared with R squared, just lenalidomide, rituximab, kind of the standard arm. The key inclusion for this randomized phase 3 INMIND study were patients. These were adult patients who had follicular lymphoma and they had to have at least one prior line of therapy, including an anti-CD20 monoclonal antibody. They could not have received prior rituximab, prior R-squared, prior lenalidomide rituximab therapy. Patients were randomized in a 1-to-1 fashion to either to the TAFA arm, so that was TAFA-len with rituximab, or the placebo arm, which was just len rituximab with placebo. It was a placebo-controlled study. Patients were stratified for progression of disease at 24 months, POD24, refractoriness to prior anti-CD20 therapy, and the number of prior lines of therapy. The primary endpoint of the study was progression-free survival. So 548 patients were randomized on the study, and a little over 270 patients in each arm. And the characteristics of these patients were, on a median number of lines of therapy was one line. Most patients had less than 2 years since their prior lymphoma therapy. About a third of patients on each arm had POD24, and there was about half of the patients had relapsed as opposed to refractory disease. The INMIND study demonstrated that there was a significant improvement in progression-free survival when tafasitamab was added to lenalidomide and rituximab. The median progression-free survival was 22 months, as opposed to 14 months with just R-squared plus placebo. Hazard ratio was 0.43. There also was an improvement in the response rate. So the complete response rate with TAFA R-squared was 49%. The complete response rate with just R-squared and placebo was just under 40%. The overall response rate was also better, with an 83% response rate in TAFA R-squared as compared to 72% in patients who received R-squared placebo. There was a significant improvement in duration of response. The TAFA R-squared duration of response was 21 months as opposed to just under 14 months with placebo R-squared. Now, overall survival was a secondary endpoint. It was just tested for futility at the time of the primary analysis, and these data need more maturity before we can fully draw conclusions from those data. If you look, the patients enrolled to INMIND really were kind of a higher risk population than prior randomized studies in a similar setting. So, for example, the AUGMENT study, obviously that evaluated R-squared. So, key takeaways from the INMIND study: the INMIND phase 3 study met its primary endpoint with demonstrating longer PFS in patients with TAFA R-squared in relapsed refractory follicular lymphoma. Overall survival data are immature at this point. The safety profile was, kind of manageable, consistent with the expected toxicities known with these agents. This was an interesting study that was the first to evaluate combining two antibodies, an anti-CD19 and an anti-CD20 antibody for the treatment of follicular lymphoma. So I think we're going to move on to our next abstract. I think I might be joined by Dr. Lunning here in a minute. So we'll get started, and hopefully he can chime in with his thoughts on this abstract looking at single-agent mosunetuzumab in patients with newly diagnosed follicular lymphoma. Welcome, Dr. Lunning.
Hello. Sorry for my tardiness. I just magically appear, on the screen.
It's okay. You came.
Did you rub the? I'm like the genie, right? You rub the lamp. You're asking. You wanted to know my opinion on TAFA R-squared, and then I'm here. You have 3 wishes.
I'm excited for my next 2 wishes, but thank you for showing up in style. Love the background. Okay, so we've talked about TAFA R-squared. We talked about LONCA R. Feel free to chime in with any thoughts on those 2, and then we'll move on to Mosun.
Yeah, I think the Lotus trial, data with regards to LONCA R and the safety run-in of 20 patients, it looked a little bit different than the initial LONCA trial in large cell lymphoma. A lot more relapsed patients, and I think that you saw as an outcome of that there were more patients who obtained a response, and in fact, more patients achieved a CR. I think the important part was that there's no additive toxicity. Not that we expected additive toxicity by adding rituximab in this patient population, but I do think that we're going to wait to see what the randomized data puts out I think, the field is starting to move beyond R-GemOx based upon, some of the other randomized trials in this space. But certainly, I think at the time that the study was planned, and now I believe fully accrued from that standpoint, we're moving forward. I know that Lonca has activity in follicular lymphoma also, and I think that that's the impressive other part here, is that when you dip your toe into kind of that single institution experience from the University of Miami, that data looks quite impressive also. So you're seeing the transcendence of active agents in large cell lymphoma. That's also, now kind of getting there in follicular lymphoma. I think the durability is really going to be the question here. It's nice to see that grade 1 anasarca went away in the latest data, which I think is just a reflection of Lonca and its warhead, if you will, the PBD dimer, and trying to manage that peripheral edema.
Excellent. Thank you, Dr. Lunning. And I think just in the interest of time, if we could, we'll just go straight to Mohsen. So if you want to let us know about this kind of single agent Mohsen study, the MYTHIC FL1 trial in patients with newly diagnosed follicular lymphoma.
Yeah, I think that this is a really interesting question, right? Can you bring something that we're now getting more and more comfortable with bispecifics, not only in large cell lymphoma, but with mosunetuzumab in follicular lymphoma? We're seeing the transition from Mosun as IV therapy to Mosun as sub-Q therapy. There is a different, a little bit more of a neurons need to fire here, because it is, different step-up dosing strategy when it's given sub-Q. And then really, what is an appropriate first-line patient population to get exposed to, get exposed to this therapy? Because you can see, and I like to start, especially in follicular lymphoma, what's the toxicity that you're seeing here? And 51% of the patients had a fever, right? We need to remember that. And so you have to think hard about, was this really a population of follicular lymphoma that needed treatment, or was just kind of doing this because they had adenopathy and they had an open clinical trial? What concerns me is that 3% of them had, grade 2. Looking by the numbers, that was probably 2 patients, but 2 patients, that probably needed admission from that standpoint. Now, don't get me wrong. Now jumping to the results, I mean, these are pretty impressive, results. I would say if they didn't look this impressive, then this trial, wouldn't have legs. So I think now, kind of in a fixed duration strategy approach in follicular lymphoma, now it's kind of a waiting game. We have 12-month PFS at 91%. Really, I think when you think about the competitive landscape in frontline follicular lymphoma, these curves are going to have to remain stable for 24, to 36 months to garner more enthusiasm.
Yeah, I agree with you. I think the efficacy looks excellent. The safety data is also what stuck out to me. And now, kind of having treated several patients with mosunetuzumab in the front line, I think we had thought of Mosun as the better tolerated bispecific antibody, right? Which was true in later lines of therapy, less cytokine release syndrome than other CD20 directed bispecific antibodies. But yeah, I think more patients are having CRS, and it tends to be more mild, but it's fevers, but more patients are just, feeling myalgias, feeling, they're experiencing the side effects from Mosun because their immune systems are, a little bit more robust at this point, right? They're not heavily treated. But I agree, the efficacy looks excellent. It's still, all in all, reasonably well tolerated. After the step-up dosing, patients do well. So, right. All right, so let's move on to diffuse large B-cell lymphoma. We're going to start off with an abstract, CAR T-cell abstract focused on rabcaptogene autoleucel in patients with relapse refractory DLBCL.
Yeah, I think that this is very interesting, because I think we have to continue to look at, where the CAR T-cell space is kind of being redefined. Undoubtedly right now, second line, high risk, large cell lymphoma, those who are primary refractory are relapsed within 1 year of completion of therapy. Axi-cell, Lysocell have cemented themselves based upon ZUMA-7 and as well as Transform, with a little bit of an extension of the eligibility with regards to the pilot data in regards to advanced age. So now we're kind of ushering in this generation of next, CAR Ts. And I think, Rapicell, in this space is interesting, because it is kind of looking like you're getting similar numbers that you had seen with the prior CAR T cells kind of going in the mix here. A fair number of patients, right? If you think about where we were with some of the seamless design trials, you're kind of in the little bit over 100 plus patients. But I pay attention mostly to CR rates with CAR T cell. PRs are, if you're not converting from a PR to CR by 6 months, that is unlikely to be durable. You're seeing about 2/3 of the patients here getting a CR, and that 12-month PFS is respectable. You're not going to want to see it dip down a little bit more than that, from the standpoint here. The other part that was interesting, I know we're not showing kind of all grade CRS and ICANS here. When I talk to my patients about the ideal CAR T cell, I work my way back toxicity wise. I look at grade 3, 4 ICANS, and then look at grade 3, 4 CRS, and then look at grade 1, 2 ICANS, and then grade 1, 2 CRS, and kind of walk through it in that landscape of having the discussion, because I think that high grade ICANS is what is the length of stay. It is what puts people in these acute rehab facilities or skilled nursing facilities trying to get better, and recover from that neurologic event. And it is quite scarring on the family. So seeing here, 5% grade 3 ICANS, I think that's respectable to kind of where we were in the other competitive landscape. I think we expect some hematologic toxicities, and we can manage through them.
Yeah, I think, I totally agree. I think it's nice to see Rapicel kind of have similar efficacy to what we're used to seeing, with the other autologous CAR T cell CD19 directed products. The safety is favorable, and I think the question is, where is it going to fit, right? And I think this rapid processing, right? If you can reduce kind of vein to vein time, that's really potentially where it can make a dent, because it's been hard, admittedly, to study other novel CAR T cells with such established products. But I agree, and I think if they can really nail that production and have that streamlined, I think it'll be really helpful.
Yeah, I think once you start to look at that vein to vein time, now will what the clinical trial specs are, will they go to kind of into the commercialization, let's say, gets there, what is those rates? But I agree with you, shortening the vein to vein time, if the efficacy can hold, right, I think is, but I agree with you. I think the crack in the door, where is it going to fit here?
All right, perfect. So let's move on pretty briefly, I think, to the POLARIX, the 5-year analysis of the POLARIX study in frontline treatment of diffuse large B-cell lymphoma with Pola-R-CHP.
Yeah, so I think that when I reflect back on this trial, and I want to find a trial to talk to medical students about, which is the best trial design, this is it, right? This is a double-blind randomized trial of putting, something that for 20 years has beaten, every competitor that has come up against it in regards to its primary endpoint, and then bringing kind of a novel therapy, polatuzumab, our CD79B antibody-drug conjugate, mano head to head, in an IPI 2 to 5 space in large cell lymphoma. Again, there was about 15% that didn't have advanced stage, so it wasn't just advanced stage only. It was really predicated about the IPI score. We saw the primary data, and we saw that as published in New England Journal, with meeting its 24-month PFS outcome in favor of Pola-R-CHP. And I think what really struck me was the toxicity. I couldn't really tell, and it appeared that patients couldn't tell, nor the investigator, if they were getting vincristine or if they were getting polatuzumab vedotin. And so when you have kind of a toxicity tornado, which looks equal to the left and to the right, and it actually looks like it from a Nebraska standpoint, like an F2 from a toxicity tornado standpoint, we're not dealing with F4s and F5s that are destructive to the body. That's a regimen that I'm willing to look at. Now, I wanted to see it mature, and we saw the 3-year data on the ODAC update where it remained stable. And then at this year's ASH, Dr. Sauls showed the 5-year update showing that there continued to be a margin there with regards to PFS. I know people will get constipated mentally on the overall, that there being no overall survival, and will want to dip their toe into the univariate analyses, looking at ABC versus GCB. But I don't know, it's hard for me to get gene expression profiling ever we typically get non-GCB versus GCB. So I've pretty much classically have adopted now Polar R-CHP as my regimen for IPI 2 to 5 large cell lymphoma.
Thanks. No, I appreciate it. I completely agree. I think practically these studies are powered based on the entire sample size, and I think slicing and dicing the forest plots, can be used. There can be some informative. There's informative. There's important information there, but I think I agree. I think it's hard to we don't want to over kind of emphasize the importance of subsets. Okay, we'll talk about kind of so we just talked about kind of some follow-up data from the first kind of novel agent to really kind of make a dent in frontline treatment of large cell lymphoma. We'll move on to two studies pretty briefly here in the interest of time. That who are the next competitors? So the first one is a randomized phase 2 investigator-initiated trial of glofitamab R-CHOP or glofitamab Pola R-CHP, the coalition study in high-risk large cell lymphoma.
Yeah, I think this coalition data was very interesting. Really, it's looking at putting glofitamab to either horse, and I think of this like adding the jockey to the horse here. Can glofitamab really steer R-CHOP and R-CHP around, and cure more patients in the first whack at their large cell lymphoma, which arguably is the best chance of odds of curing large cell lymphoma. And here you see it. I mean, the first step to curing large cell lymphoma is getting into a metabolic complete response, and you had 98% of both populations getting into a complete metabolic response. That being said, as the tail of the tape, and now paying attention to who are those people who, after completion of their therapy, stay in remission for over a year, which we know the vast majority of relapses, if they're going to occur, they're going to occur within that first year. You can see 90% with glofit R-CHOP and 95% progression-free with glofit R-CHP. So I know we're going to lean into Hodgkin's next, but it bleeds that question, of how high do we need to get in diffuse large B-cell lymphoma in order to start to chip away at the CHOP, or the CHIP portion. And I think truly with the addition of polatuzumab vedotin and glofitamab, we're doing the randomized trials in the STARGLO, the SKYGLO trial, to help answer that question. I really think that's a huge trial, going to be one of those another landmark trials. We have a lot of landmark trials right now going into the randomized large cell space, but I think this was a good teaser, if you will, to the bigger randomized trials.
I agree. The efficacy are impressive. I think dealing with a little bit more fever, a little bit more CRS, and it gets a little more complicated, right? Extra visits. But
the toxicity tornado here was definitely above the Polarix. I would say this was an F3, borderline F4, with regards to how we had to learn really how to give glofitamab with these agents. And I like kind of the staggered approach of getting one cycle in, getting the disease burden down, and then introducing the bispecific. So I think that we're going to figure out how to give bispecifics and combination chemotherapy in a practical and real world, really forward mindset.
Excellent. Well, not to give short shrift to Hodgkin, just maybe one word about the golcatamide R-CHOP study in frontline treatment of large cell lymphoma. Just maybe another potential competitor here.
Yeah, I think Golca R-CHOP has in very interesting data. I think they figured out the right dose of Golca to go with R-CHOP. They chose to ride, if Golca's the jockey, they've chosen to ride the R-CHOP horse here. Impressive MRD undetectable in 90% of the patients. So I think that the GOLSEEK trial is accruing globally. So this one is moving forward also. So we have no shortage of great randomized trials for our large cell lymphoma patients.
Awesome. All right. So we're going to move on to Hodgkin. And
yeah, so Hodgkin's lymphoma is, I know that you're steep deep in the Hodgkin's lymphoma landscape here. And so, I want to spin it back to you, Alex, since I was late, and I'm going to rub the genie here, and I'm going to have you pop out and kind of tell me what you see was exciting at ASH, and we'll go to the next slide. But so we know about BV AVD. We know about Nevo AVD. I mean, you certainly know about Nevo AVD because I call you about it all the time. but now we're even moving outside of advanced stage into kind of non-bulky early stage. Tell me a little bit about what excited you about this trial.
Well, I think, in terms of rubbing the genie and getting some wishes, I think at Hodgkin lymphoma, we've had this abundance of the genie's really popped out, and we've made a real important dent in the curability of this disease with novel agents. And so, now in advanced stage disease, we're talking with Nivo-AVD and BRCAD and HT21, we're talking about curing more than 90% of patients with advanced stage disease. So how do we, the bar is higher in early stage disease, right? Patients have better outcomes. So how do we incorporate these drugs into frontline therapy of early stage disease? This is a study adding both brentuximab vedotin and nivolumab, combining it with doxorubicin and dacarbazine. So dropping bleomycin, dropping vinblastine. This is an updated analysis of a phase 2 study, early stage, non-bulky patients. The efficacy was great. The complete response rate was 92%. The estimated PFS at 2 years was 97%. Really spectacular, with less chemo and no radiation. And this was just 4 cycles for non-bulky early stage disease. So impressive efficacy. Favorable and unfavorable patients had similar outcomes. Favorable PFS, 2-year PFS was 100% in favorable patients, as opposed to 95% in unfavorable disease. Overall survival was 100% at 2 years. So really, I think these are the 2 most potent agents that we have for the treatment of Hodgkin lymphoma. Finding ways to reduce cumulative toxicity related to chemotherapy, omitting radiotherapy is exactly where we're thinking we want to go, and how we incorporate these drugs into the front line.
It's great to see, people putting their oncology, hats back on and thinking about, and prioritizing drugs, right? And saying, if I rank list drugs, what drugs would I get rid of first? And, where would I fill them in? And I think we've certainly nailed it here. I know this is an advanced stage Hodgkin's lymphoma, similar type of regimens have been going on. What was the toxicity with this? Are you seeing a lot of diarrhea with the BV and the Nivo combos, or not so much in this study?
No, I guess I would say, because this is a shorter regimen. So when we give it for 6 cycles in advanced stage disease, we see a little bit extra immune related tox. We see a little bit more neuropathy than we would with just Nivo-AVD. But I think the shorter duration helps a bit there. But make no mistake, brentuximab combined with Nivo probably adds a little bit more toxicity compared to Nivo-AVD. All right. So I'm excited to kind of talk about the next study, because, we've seen how these novel agents have, we're talking about the front line. Well, in relapse refractory disease, bringing brentuximab and Nivo and pembrolizumab into second line therapy really moved the needle, right? So we now, patients with primary refractory or early, or relapsed Hodgkin lymphoma, we were able to historically cure maybe 50-60% of them. When we brought PD-1 blockade into the equation in relapse refractory disease, we were curing upwards of 85-90%. That was remarkable. So the important question that everybody wanted to ask, do you still need a stem cell transplant for patients with relapse refractory disease? And so Memorial Sloan Kettering did this study. Alison Moskowitz led this study at MSK, looking at Pembro GVD. And for patients who were in complete response, they just got Pembro maintenance instead of a transplant. There were 39 patients enrolled. And I guess what I'll say is, we had to think about what was our expectation beforehand. I personally wasn't expecting that we were going to see 85-90%, kind of durable, long-term PFS in these patients. What we saw was 2-year PFS of 60%. That's pretty darn good. I think if you want to think about what's my best chance of curing the patient, I think unquestionably still, with these data at least, doing a stem cell transplant looks like the right thing. But if these are young patients, many we get all the time, patients come and they're asking, do I really need the stem cell transplant? And these data suggest that maybe a majority will stay in durable remission without a stem cell transplant. I think that's impressive. Of the patients who relapsed, there were 10 relapses. 9 of them ultimately got to a stem cell transplant, right? So it's not getting rid of stem cell transplant. It's really deferring it, right? You say, who's going to be in a durable response? If they don't achieve a durable response, then I can still get them to a transplant. It's saving the kind of morbidity and process of transplant for those patients who really need it.
Do you think you can start to risk adapt now that we have these? And I think the field is shifting, right? So now, I'm actually thinking about dusting off my BV Benda. Maybe we need to recut that data to look at the long term, because if we have Nivo-AVD up front, now we're going to have a bunch of BV, naive, patients to think about. Now Athera becomes cool again, or
Right,
does
right.
it not become cool again? So I think we're in a very interesting inflection point in Hodgkin's lymphoma.
Yeah. I think the one thing I would say is they did see that stage 4 patients, if they had stage 4 disease at relapse or primary refractoriness, those patients didn't do great with a no transplant approach. So I think we're almost at time. I guess
Yes.
Yeah, I'll just briefly mention there was a randomized phase 2 study. Interesting, similar to the first study that kind of brought in BV/nivo right up front, combined with doxorubicin and dacarbazine. This study did it in an adapted way. Patients received 2 cycles of standard ABVD, and then if they were PET2 negative, they received either BV/nivo or just a little bit more chemotherapy and nivo alone. And just to kind of cut to the chase, actually the PET2 negative patients, so after 2 cycles of ABVD, incorporating either nivo or brentuximab and nivo, the 2-year PFS was 100%. So no relapse, no death. Similar to what we saw in that first study, bringing these agents into the front line, potentially can allow us to reduce the cumulative amount of chemo and potentially omit radiation. The patients who were PET2 negative got escalated to BV/AVD, followed by nivo. Outcomes were reasonable, certainly not worse than BA-COP. And the patients who had bulky disease had reasonably okay outcomes. I think we still have some room to improve there. But overall, again, supporting this randomized phase 3 study that we're doing in the cooperative groups, looking at incorporating BV/nivo into initial therapy for early stage disease.
All right. Well, I think that wraps us up. I apologize for all you here in social media land that are watching us live for being late. I think that it's always great, though, to get to speak to you, Dr. Herrera, whether or not I'm early, on time, or late. So I want to thank you for participating in this activity. To claim free credit, you can click on this QR code here. And both Dr. Herrera and I will now hop back into our magic what's
Genie
the word?
bottles?
Our genie bottle. Yes. All right.
It's a great image to leave everybody with. Thank you, everyone, for your participation. Appreciate it.